Okay, hi, everybody. Thank you so much for joining. And I hope you had a chance to have a look at the ECG that we'll be dealing with today. So it's quite an interesting one, and hopefully one that you can learn from as well. And I hope those who had a chance to look at it before the meeting maybe had some idea of what was going on and why the ECG looks like what it does, because it's a very terrifying looking ECG when you just look at it on the face of it. And if you look at the history, I mean, this is a 61-year-old asymptomatic man. Now, this patient would have given you a history of previous ischemia, of previous problems in terms of the heart, possibly previous bradycardias, things like that. And then you get this patient coming to you in the emergency department and outpatients department. And maybe he's coming for, all right, here it says asymptomatic, but let's say he's coming in for, chronic gastro, or he may have dislocated his shoulder, something like that. And on the monitor, you notice these ECG patterns in your regular ECG. And from that, I'm so sorry for the noise in the background. There's just a little one. Uh, uh, and the kids at 3 and 4 years old can be quite noisy sometimes. So let's just have a look at the ECG itself. My apologies for the play in the background over there. I hope it doesn't distract too much. So anyway, as we were saying, so you put him on the ECG monitor, and this is what you find. So if you're a doctor who's now followed this particular series of lectures and you've been with us for quite some time, when you are faced with this in the future, you'll actually come out of it looking very well. If you're somebody who's not really that good with ECGs, you will immediately panic. Now let's look at what's going on and let's try and figure out what it looks like. What does the ECG look like? You just have a look at it. So you've got lead 1 and lead AVF that are pointing in different directions. And in fact, in this case, it will point towards a left-sided axis, with lead 1 being positive and lead AVF being negative. Then if we had to look at the rate, I just want to get into the rate before the rhythm. You should look at the rhythm first. The rate is about 1, 2, 3, 4, 5. So it just under 60 beats per minute that we can see over there. And as we look at each individual area, so if we look at the inferior part of the heart, we notice the Q wave and an ST elevation, another Q wave and an ST elevation, Q wave, ST elevation. So for those of you who watched before, we can see this is a left bundle branch block. And it's a discordant ST segment. What that means is that if the QRS complex is going in one direction, the ST segment is going in another direction. Oh, I'm so sorry. You can't hear me at all. Let me just test the speaker. I'm so sorry about that. Excuse me, just hold on. Let me just check. Let me just pause here. I'm so sorry about that. Let's just. All right. So I'm so sorry about that. It seems like we've been having a bit of an issue with the audio and the recording, but okay, the audio and the recording are back. To those of you who are now with me, my apologies. We have to go just a minute back just to, explain everything to everybody, that we had an issue with one of our participants couldn't hear, and now we're back on, and we were going through. Like I say, let's have a look first at the axis. So we had lead 1 going up, lead AVF going down. And with lead 1 going up, that implies a left-sided axis. We looked at the rate. The rate was just below 60. But looking at this, we see we've got what is a typical left bundle branch block. And previously, we had spoken about left bundle branch blocks and a discordancy and concordancy. So discordancy meaning your QRS complex goes in one direction and your ST segment is in another direction, or is on the opposite side of your electrical neutral line. That's discordancy. Whereas if you were to have a QRS complex and let's say your ST segment was on the same side, that's called concordancy. And in previous ones where we've talked about left bundle branch blocks, what we've said is that if there's concordancy, there's a high possibility of ischemia. And with concordancy, if you had very bad concordancy, greater than five small blocks, like for instance here, you would say maybe it's just about higher than five of the small blocks, maybe here about 2.5 to 3. It's a high probability of an MI. Now, as I had said before, if somebody has been not really studying, keeping up with the ECGs and the different types of ECGs that we see, you would, of course, get worried. You would start looking just at that, and you would start getting the patient off to your cardiologist and your physician. They'll come and look at you, and they'll have a bit of a laugh, and they'll go on their way, and you'll be very disappointed, and you'll wonder what's going on. And the reason for that is, if you had a chance to look at this before, is that if you go through the ECG, you'll notice these little spikes, what look like little lines that are just suddenly appearing in the middle of the ECG. Now, these are very important to recognize. It doesn't matter whether you're working in anesthesia, surgery, emergency medicine, medicine itself. These are pacemaker spikes. Okay. So these that we see here, all of these are pacemaker spikes. So when you see that, that's when the pacemaker is giving off a little shot of energy into that atrium, sometimes to the ventricle, depending on what type you have, but most commonly into the atrium. And that's what's leading to what we see here. Now, in seeing the pacemaker spike, it doesn't mean everything's fine, but it kind of gives you an idea of why this doesn't look like how it looks. Now, in this particular case, the ECG of a patient with a pacemaker should look like this. You should have a left bundle branch block with discordancy. I hope you're following that. So you should have this wide QRS complex that looks like a left bundle branch block, and your ST segments should be on the opposite side of the neutral line. That's what it should be. It should be relatively regular. You should see the spikes at a regular interval, depending on what type of pacemaker the patient has. But this would then be regarded as normal. Now, of course, if the patient is symptomatic or has evidence of failure or is still bradycardic and things like that, even if they look like this, there is still a room for you to go and call the physicians, cardiologists, because there is a possibility that the pacemaker is not working. But this is how an ECG should look. Now let's get into the nitty-gritty of pacemakers, because it's important, because I was actually sent one of these recently, and the person who sent it to me was extremely worried that the patient was actually in need of emergency treatment, and had to go through it and explain to them why that's not the case. So in this case, we've got what we call an atrioventricular sequential electronic pacemaker, which is the most common pacemaker that you normally see. You get on demand, and this is the other one I'll show you now. But what happens here is that the atria is paced, and it's indicated by an initial pacemaker spike. So this little thing here is called a pacemaker spike. And that's when the pacemaker is sending off its little bit of electricity. This is then followed by an atrial complex, which is then followed by another PS complex after preset delay. Now, that may be difficult to see on this, but you get your pacemaker spike, and then you get a little PS that you can see over there, your atrial complex and a little PS. All right. Atrial complex, little P wave over there, but you can't see the PS. I think this one here probably gives you the best indication of that PS complex. All right. So that's where you see that. And in fact, in this one here, you can't even make out the pacemaker spike because of the orientation over there, Here you can actually make it out a little bit better, where you've got the atrial movement over there. All right. So the second PS is immediately followed by the QRS complex. Now, what I want to point out here is that very often, if you look for the PS and the second, atrial complex, it can get very difficult because, for instance, like here, all you see is the pacemaker spike, and everything else is buried. So the more important thing to look for is the ventricular changes. So with the successful capture, in other words, the pacemaker is doing its job, the ventricle will depolarize, so it will contract, but they have the morphology of a left bundle branch block type, which we see. And they have ST segment T wave discordance, which we see. the most important finding is that each pair of the PS is followed by ventricular capture, indicating proper functioning. So in other words, you should see pacemaker spike, PS, which we can see there a little bit, and your ventricular capture. I hope that makes sense. If it doesn't, please stop me and let me know. You need to have a good understanding of how it works. So pacemaker spike, little atrial complex with a little PS over there, which is not always visible. But the most important thing is that you get the wide QRS complex with an ST segment or T wave that's on the opposite side. So it looks, exactly like how it's supposed to look here. If it was on the same side, it's very indicative of poor capture. In other words, the pacemaker is not doing its job. Okay. So and it shouldn't even be well, it can be even, but ideally it should be discordant, all right? It should be on the completely opposite side. Okay. So let's have a look at some examples of this. So here we can see the little PS over there, all right? So that's the initial depolarization with the wide QRS complex in leads 1 and 4, which they haven't really indicated here. Here we see the appropriate discordancy, which is what they're trying to show us here, right? How it should look. So above and below your neutral electrical line. So if your QRS complex is above, your ST segment should be below. If your QRS complex is below, your ST segment should be above, and they should be wide. Okay. So we see the pacemaker spikes, and in some cases we see these I'm so sorry about that. And we can see, the QRS complexes that are formed after that. But basically, the important thing is to remember this discordancy and your left bundle branch block type picture. If you get this, then you know everything is okay. The reason why I mentioned this also, some of our machines, especially in South Africa, some of our machines are sometimes a bit older. They're not the latest models. And some of the latest models actually pick this up and immediately tell you. So if you're lucky enough to have the newer model, it'll actually tell you pacemaker spike. It'll actually tell you appropriate accordance, proper capture, so on and so forth. On some of the older ones, it may pick up the spike, but it may not necessarily tell you whether the capture is okay, But I know on some of the newer ones, it tells you exactly all of those things. So let's get a little bit into pacemakers and ECGs. So the one that we saw here, which is an AV sequential pacemaker, it coordinates both the atria and the ventricles to maintain synchronized atrioventricular contraction. So in other words, it stimulates the atrium and then stimulates the ventricle and gets both of them to pump at the same time. So what are the key features to look for, which what we had seen? Pacing spikes, which are small vertical lines preceding the atrial or ventricular depolarization. The capture of the heart, so the heart's response to pacing, which is indicated by appropriate atrial or ventricular depolarization following the spikes, which in this case we see, even if we can't see all the features, but we do see the depolarization or the contraction. And of course, the QRS complex should be that of a left bundle branch type morphology with discordancy, all right? So what is the concept of capture? What does that mean? So atrial capture is that a pacemaker spike is followed by a P wave. Ventricular capture is that is then followed by a QRS complex. All right. So in other words, the pacemaker shoots, the atrium follows, and then the ventricle follows. That's how it should be. And 100% capture means that all of your spikes and your atrial complexes lead to a QRS complex depolarization, or they can even classify it as each spike getting an atrial contraction as well. Now, what are the clinical implications to ensure the pacemaker is functioning effectively and to, of course, make sure that you don't send the patient off for inappropriate investigation? But we'll get to that now. So the pacemaker stimulates the ventricles. That's why the QRS complexes are wide, unlike a heart that's normally stimulated by just the atria, which is something we've gone through before. And then the ST segment and T wave show discordance, which we've talked about. So positive is when the QRS is pointing upwards and the ST segment is depressed and inverted T wave. So in other words, the QRS complex is up, the T wave and ST segment are down. And then negative QRS is where the QRS complex is down, but your ST segment is elevated and your T waves are up, right? Which are quite easy to see on our ECG here. So a positive QRS, negative ST segment. Negative QRS complex, positive ST segment. And even when you're pacing a patient with a let's say in your emergency department, this is what we are aiming for. That's what we want to see, you know. And it matters because it's a normal finding and it should not be misinterpreted as ischemia or infarction. Okay, so what are the different types of pacemakers that we get? And hopefully we'll discuss these over the weeks. An AV sequential pacemaker, which stimulates both atria and ventricles. A fixed rate mode that you can get on these, which fires at a preset rate, regardless of what the heart is doing on its own. And there are reasons why you have those types of pacemakers. And you have a demand pacemaker, which fires only when the intrinsic rate falls below a programmed threshold. So in certain patients, they may have, for example, sick sinus syndrome or something like that, where they most of the time they are okay and they can go into tachys, but occasionally they go into severe bradycardias as well. And that's when the pacemaker may kick in. And it's important because we need to understand pacemakers in terms of ECGs when we're working in a department, just so that we don't sound the alarm bells for nothing. Now, of course, if you're not experienced with pacemakers and you're not experienced in reading or making sure that they're 100% okay, the most important part is at least being able to tell the person who you're asking that, listen, this is a pacemaker, but I'm not sure if everything is 100% okay. Could you please have a look for me? And of course, if your patient is symptomatic and your patient has evidence of ischemia or is presenting with signs of cardiac difficulty or is bradycardic or whatever it may be, then of course you need somebody to be able to look at it, to be able to tell you that there is a problem. Okay. So what are some of the problems with pacemakers? Sometimes they fail to produce a capture. So in other words, you get the pacemaker spike, but afterwards there's no atrial or ventricular depolarization. The oversensing, which means the pacemaker is inhibited by non-cardiac signals, leading to underpacing. Now, this may happen when you have extrinsic pacemaker cells. So in certain people, their hearts have extra conductive pathways or extra pacemaking cells. And even though the pacemaker is in place, these are actually the ones that are producing the signal to the ventricle, and this can sometimes lead to a problem. And then, the pacemaker can then underpace. And then undersensing, where the pacemaker fails to recognize the intrinsic beats, and it leads to unnecessary pacing of the heart as well. So this normally requires adjustment of the sensitivity and voltage thresholds. This is normally done at a cardiac pacemaking unit. It's not something you can do on your own. There's a specific way that they do it. You know, it's external. There's such lovely pacemakers now that via Bluetooth, they just connect to a computer program. Everything is done. Some of them even have Wi-Fi ports that, Wi-Fi connection. There's so many things that they can do to actually make sure that the pacemaker is functioning properly. So again, why does it matter? Why do we need to know? So we don't want to cause unnecessary interventions. We want to differentiate between normal pacemaker behavior and pathology that's crucial in emergency scenarios. We want to make sure that we pick up what's going on and that we identify the spikes and we can see the atrial and ventricular depolarization, because these are the most common types of pacemakers. And we need to understand that rule of appropriate discordance to prevent the misdiagnosis of ischemia. So we don't want to suddenly be sending patients with pacemakers for TROP-Ts and CKs and, booking them in for the cath lab and, all of that, because not only is it unnecessary for the patient and very distressing because they've previously had cardiac problems, but secondly, you really look like a fool if you don't pick it up. So that's the reason. And of course, the last is to learn and recognize pacemaker malfunctions and differentiate them from normal function. So I hope you guys picked it up. I hope you guys understand. For those of you who have joined now, I hope it makes sense. If there's any questions, please ask me now in the chat, or you can ask me later on if you think of something. And for those who are watching later, I hope you understand as well. And if there's any questions, because I know it can sometimes be a bit of a difficult topic, but I hope this one here, by showing you what a normal ECG with a normal ECG pacemaker should look like, that you'll be able to then pick up what's abnormal. So if you see narrow QRS complexes, concordant QRS complexes. So you get this wide complex, but if the QRS is positive, the ST is also positive, immediately something is wrong. If you see that every time you have a pacemaker spike, you're not necessarily getting your depolarization of your of your atria and your ventricles. This is just a little joke to finish off, and it's pacemakers have come a long way now. Hopefully, they don't do that anymore. But hopefully, if you haven't seen pacemaker ECGs before, I hope you will have a look at this, because even when you are doing transcutaneous pacing, transvenous pacing, this is what you are aiming for as well, to say that you have electrical capture. So when you put your pads on and you put your defibrillator in pacing mode and you start doing your pacing, this is eventually what you're aiming for. When you've got the correct amount of joules and you've got the correct rate, then you'll see something that looks similar to this as well, because it's also a sequential pacemaker at the end of the day. The only thing is that an implanted pacemaker does that on a 24-hour basis. And in the emergency department, we're doing it on a emergency basis to make sure the heart remains as it is. So I hope everybody understood. If there are any questions, more than welcome to let me know. Even if you can't think of them now, you can always let me know later. But what we'll do is that we'll actually stop right here, and then hopefully on Wednesday we'll have another one. Okay, thank you very much. Bye.